Deepa, let's start with you. Help us understand what is driving this increase in mental health and well-being concerns for our North Carolina residents.
Sure, and thank you so much for having us all here today to talk about this very important issue. I think all of us have experienced major changes over the last 2 years in the way that we live. And when those types of changes occur, there are significant effects that you can have related to your mental health. So when you have increases in grief, loss, stress, trauma, unemployment, financial stability issues, and even just an impact on your daily routine. For many individuals, that will cause issues related to negative mental health consequences.
So let me stay with you for a moment. We heard the statistics about the rising number overall of adults experiencing mental illness, but I can't get my head around 1 in 3 young adults 18 to 24 are experiencing mental illness or have during the pandemic compared to all adults. What's causing this?
Well, if you think about it, 18 to 24-year-olds, it's a period of time we refer to as transitional age youth because they're already in a quite stressful time for many people. While it's an exciting time in life, it's a time of change, it's a time of transition, it's also quite stressful to go from being a youth to becoming an adult, to coming into your own, gaining independence, gaining access to different types of life that you haven't lived before. And to have that on top of a pandemic with all of the stressors that came with social isolation, staying home, being away from your peers in many cases, or going to school differently than you normally would have, that has caused a lot of stress for our transitional age youth.
Thank you for that. So Anna, we've got the numbers going up and wait times for therapy sessions can be weeks, sometimes even months. How did the mental health care system get so overloaded so fast?
It's a great question, and thank you also for having me again, Dr. Brown-Graham. As Deepa said, I think that there are a number of immediate consequences of the pandemic that caused this. But unfortunately, I think we're also on the heels, as was mentioned in the video, of long-standing deficits in the number of mental health professionals that we need, be that psychiatrists, psychologists, social workers, folks who are just there in the community to support people who are in need. And so with the increased need and the same or sometimes even less, because certainly some health professionals were pulled in other directions, public health professionals were pulled in pandemic directions, there was, just as was mentioned, almost a perfect storm of not having the resources there to meet all of the need that was increasing.
So, Denise, this is a statewide show, but we always want to recognize that all things don't affect all places in the same way. So let's talk a little bit about some of the geographical disparities. What unique challenges do people who struggle with mental health face in rural counties in North Carolina?
Again, thank you for having me here. I'm happy to be here. Rural North Carolina, that hits close to home. The biggest barrier, well, I'm not going to say the largest, but is access to care. Access to care. How do I get there? Where do I get it from? How do I afford to get there? Coming from, and I'll use me as an example, small town, country town in North Carolina, and the closest mental health facility there is 30 miles.
Which small town in North Carolina? Go ahead and tell us. Tell us. We want to know.
I grew up, have my life in a town called Pantego.
I know exactly where it is.
Outer Banks off the Pamlico Sound. And their access to any type of health care is limited. But when you talk about mental health, the nearest place is Washington, North Carolina, and that's a 30-minute drive. So if I don't drive, and a lot of people in rural North Carolina can be without licensure, they don't need it. Somebody is down the street or somebody's going to pick me up. They know everybody. They don't need it. but I need somebody to pick me up and I need somebody to take me there, and then I have to pay them for the gas. I have to have them sit there with me all day. That's a big challenge sometimes, and it deters us from meeting appointments or being able to even schedule them, because I just simply don't know how I'm going to get there.
Yeah. Thank you for sharing that and for personalizing it. I appreciate that. So Deepa, you've heard what Denise just said, and we heard in the story about this 988 rollout in July. What impact do you think this new mental health crisis hotline will have?
Sure, and if I could just add to what Denise just said, one of the things that we're doing at the Department of Health and Human Services is trying to make sure we're taking advantage of things like mobile units, where we're trying to address the exact problem Denise just described. So in order for a person to gain access to treatment, if they can't travel 30 to 45 minutes or an hour, we're bringing the treatment to them via mobile unit. So we are providing services via mobile unit for substance use disorders, for mental health services, and for integrated physical health and mental health care as well. So I just wanted to make sure that came across before I address the 988 issue. I think 988 will be a huge game changer for people. I will say that there is currently a suicide prevention lifeline, which all North Carolinians can access. What this does is it allows individuals to access that help with simply remembering a 3-digit number. So you don't have to remember what is the 10-digit number to reach this National Suicide Prevention Lifeline. You can remember a 3-digit number, 988, and beginning July 17th, you'll be able to access 24/7 access to trained crisis counselors who will be able to assist you on the spot. If additional help is needed, we'd be able to provide follow-up care and also mobile crisis teams if needed.
So this works if people are willing to pick up the phone. Anna, we've come a long way in working to eliminate stigma around mental health, but let's talk a little bit about the challenges that still remain in breaking this challenge.
Well, I'm so glad you mentioned that, because one of the hopes that I have, and that I know other folks have about 988, is that it can contribute to breaking the stigma. We've seen a lot of strides made since the pandemic, because folks are in general able to start recognizing that this is a universal trauma that we're having that is affecting people and people's mental health. And what I hope 988 does is allow an opportunity for people to put it right up there with 911, to understand that mental health crisis and mental health needs are just as important and just as critical to be responsive to as physical health needs, like you might call for 911. But it's still a struggle. We're still seeing underserved populations, in addition to rural populations, as Denise mentioned, populations of people of color, many of our native populations, and then in general, even in urban environments, people of color have generally used the mental health system less. And a lot of that has to do with stigma and trust and historical trust of healthcare systems. And so I think we need more providers of color, we need more outreach, we need more support, because the stigma and the access is, as you're alluding to, not equal.
So I see Denise nodding vigorously. Denise, do you want to weigh in on this?
I am. She hit close to home again. We do need more providers. We do need more people that we trust, that we can relate to, or that we think can relate to us. I'm going to put a disclosure out there. I just graduated with my ncIMPACT. So it is really, my drive was certainly that. It was, growing up and not knowing it existed. We didn't talk about it. You didn't hear people talk about it. And in my adult life and having worked with mental health patients, I can think back to, well, was that what I was seeing? We kind of blew that off, but did Uncle Joe, was that what I was seeing? And just talking about it. And so talking about it, doing something about it. My hope is to go back and be that educator, to be that person that people feel comfortable with, so that we can start having those conversations. And I hope with the 988 line that, people feel like even if it's still the stigma around it, that we can still call. Nobody know I'm calling, so I can call and I can get some of the help that I need. Like, I can see lots of possibilities there.
That's terrific. Thank you for doing what you're doing. Anna, let me ask another question about barriers to you. Around a quarter of adults who experience anxiety or depression symptoms don't receive care for it, according to a study by the Kaiser Family Foundation. That's a lot of people with no health supports. Thank you, Denise. Why is that? I just help our audience understand what's happening here.
I think many of the barriers have been mentioned. Deepa mentioned a slew of them earlier. Transportation, having time and money for transportation, people working 2 and 3 jobs, having time to fit in a mental health service in their life, especially if they don't perceive it as serious or severe as a physical ailment. And the stigma surrounding getting help too. And so access to care has a lot to do with social determinants of health. And so things like the ability to take time off work, transportation, childcare, how do you even know where to look? Do you have health insurance? All of those things play into that. And one of the benefits of the pandemic that we've seen to actually help hopefully increase those numbers of people getting services is the advent of telehealth in the mental health service arena. So if we can actually bring mental health to the person, and Deepa mentioned mobile crisis units or mobile units as well, that gets over a number of barriers. But stigma, mistrust of the system, and things like that remain.
Just want to add to that. In looking at it, you mentioned telehealth, which is coming. It's really on the rise. But we also have to make sure that in offering these things that they still have the things to make that happen. For example, you can put telehealth in a rural community, but if I don't have cable and I can't get to the internet, then I can't utilize telehealth. Or if I have one phone, which is a cell phone, and I am in rural North Carolina and it's spotty service, I can't hold the call. So it's bringing those, but it's also looking past the service and what barriers lie past the service, if you will.
So true.
Yeah.
That is so true.
So, access isn't always access if you can't get to it. Deepa, how's the state thinking about telehealth and that opportunity to serve the underserved in North Carolina?
Sure, yeah. One of the things the state did right away at the start of the pandemic was really put in place flexibilities to take advantage of some of the telehealth flexibilities that were offered by the federal government. So North Carolina has really done a good job of making sure that telehealth is accessible to individuals across the state. I think absolutely the infrastructure issue is an issue, and it is something that we are looking at to make sure that we're reaching rural communities as well. I also think that while telehealth has been supremely important, and I personally believe really saved our mental health care delivery system, it is not a replacement for a face-to-face delivery system of care. So we really are looking at making sure that face-to-face access to care is still accessible, is still available, and while we are also doing telehealth as well.
So could you say a little bit more about that, and then we're going to go to some more questions from our audience. But if people are trying to figure out, does telehealth work? Do I really need to see someone in person? Are there any best practices or checklists that help you figure out what you should be getting?
I think it's up to an individual and their provider Really, one of the things, the benefits of telehealth, what it really also did was it took away some of the stigma of sort of, it was easier for some people to be able to access care from their home versus being able to go somewhere to do it. It kind of took away a little bit of the mystique of gaining access to mental health care. So I think for many individuals that's perfectly fine and acceptable. But I think for many individuals with more serious mental illness, for example, telehealth may not be the answer. So I think it's really on a case-by-case individual basis, and a provider and client can work on that.
Terrific. Well, let's take some questions from the audience. Anne from Raleigh asks, why do so many mental health care providers refuse to file insurance claims for their patients compared with other healthcare providers? Insurance is difficult to navigate at the best of times, amen, Anne, and more so when there's a mental health issue involved. Who wants to take that?
I'll start, but I don't have the answers, all the answers. Because it's a very tough question. I think exactly as you've described, and there are some instances where mental health providers do not take insurance, and it's puts the onus on the patient in some cases. And I think we're working against that. So I think mental health parity laws, which have been enacted for quite some time now, that require the insurance companies to provide coverage for mental health care, have hopefully supported increased access. But I do think that we also need services. We need people to help folks navigate their insurance and their insurance claims. And some insurance payers, are, to be fair, are providing these types of services. But more can be done exactly for the reason that she described, that folks who are experiencing a mental illness or a mental health crisis might not have the resources at that moment that they need to navigate the system.
We're expecting people with cognitive impairment, executive functioning impairment, to navigate a system that is hard to navigate at best. That's what we're expecting.
Yeah, it doesn't really make a lot of sense. Oh, we'll take another audience question. This one is coming from Carborough. Elizabeth asks, what are the main barriers to expanding access to telehealth? Is it broadband? Is it the lack of computers in the homes? What? If we had to check off a list, what would it be? Deepa, you want to take a stab at that?
I think some of the barriers are what was described, some infrastructure barriers. I also think in general right now, we also have a workforce crisis. We have a lack of practitioners across the behavioral health care system in the country, and that is producing barriers not just for telehealth, but for the delivery of care in general on the behavioral health side. So I think both there's an infrastructure issue as well as a human resource issue as well.
And so, Deepa, can we talk about workforce, because that's such an important issue for my work. I feel like I wake up all day thinking about workforce issues. But Anna mentioned that during the pandemic, there was sort of a shift of attention toward immediate health issues associated with COVID-19, and that left less capacity for other things. Should we expect then that the workforce shortage will resolve itself as things normalize, or is this a longer-term workforce shortage that requires a different prioritization?
Well, I think there's a couple of things to consider. One, we were already on a little bit of borrowed time in terms of the behavioral health care workforce. We were not starting from a surplus of behavioral health workers, as Anna had mentioned also. So we were already starting with a little bit of a deficit. But then, coupled with that, you're also adding a humongous demand, which was what we've been discussing, right? We've been discussing increases in anxiety, stress, grief, trauma, all of these things, which put an increased demand on a sort of a shrinking supply of workforce. So some of the things that we're doing, or some of the things that were mentioned here, was looking at doing additional fellowships, doing additional reach out to colleges and universities like our HBCUs to build the pipeline of providers who will be ultimately interested in working in the behavioral health space.
That's terrific. All right, I'm going to take one last question from our Facebook audience. Sorry, Facebook audience. This one is coming from Chapel Hill. Oh, triangle today. Does the fact that North Carolina hasn't expanded Medicaid impact mental health care access? And will telehealth continue to be covered by most healthcare plans once those temporary provisions for parity go away?
So in terms of the Medicaid expansion question, I think it would be an enormous benefit to our ability to provide behavioral health care services if we expand Medicaid. It's almost innumerable in terms of the extent of that benefit. So some of the things that we've been talking about here today, transportation, housing stability, employment services, recovery support services, other states that have expanded Medicaid, what they're able to do is use different funding sources to provide for all of these wraparound services that are so necessary. For us, we have to use those funding sources to provide clinical treatment. So I think it would allow for a much more robust ability for us to provide care and services. So I do think it would have an enormous impact on behavioral health care delivery in the state.
Terrific. And Denise or Anna, do either one of you have some sense around whether payors will continue to pay for telehealth at parity post-COVID-19, whenever that may be?
I think so. I don't think telehealth is going to go anywhere. I think that we had to learn to use it. We had to learn to use it fast. And I think we'll continue to work on it, and it'll probably stay. That doesn't mean that it will cover as extensively as it may today, but I don't think it's going to go anywhere.
And I am concerned that there may be some pushback and some regression of coverage of telehealth services. But at RTI and certainly other researchers, we're working to try to understand how telehealth relates to face-to-face services. And initial indications are that it can be as effective as face-to-face services for some folks, for some populations. And so I think the more that we can show that, the more likely we are to continue reimbursement.
Anna, Denise, Deepa, thank you, thank you, thank you. Thank you for all the work that you're doing, and thank you for sharing your time and insights on this important and heart-wrenching topic.